morning, everybody. This is Friday Chalk Talk. We are delighted to have everyone here today, but we are, of course, most excited about our speakers for today. Excuse me. I have the authors of this wonderful paper, but my mom still blinks when I talk to her. Understanding the concept of social death to avoid bias and improve goals of care discussions at end of life. This is by Joelle Robertson Preidler and Holland Kaplan. They are going to give us a little bit of a talk and leave room for questions. I just wanted to introduce them though. Joelle is an assistant professor at, oh my goodness, my thing just changed. Sorry. Is an assistant professor at McGovern Center for Humanities and Ethics at the University of Texas Health Science Center at Houston. Before she was there, she was an assistant professor at Baylor College of Medicine, and she's done clinical ethics consultation and research. Her research and teaching interests focus on equitable communication and decision-making for patients near end of life. So this is all totally in her wheelhouse. She's a theater nerd, and she tries to incorporate elements of theater and improv into the medical school classes that she teaches. And I think we've had a talk before here about improv stuff in palliative medicine as well. So we are totally on board with that as well, Joelle. Holland is an assistant professor of clinical ethics and general internal medicine at Baylor College of Medicine in Houston. She practices hospital medicine at Ben Taub Hospital and serves as an ethics consultant at Baylor St. Luke's Medical Center. So not our St. Luke's, different St. Luke's. Her areas of interest are medical education, ethical issues involving decision-making capacity and unrepresented patients, as well as care for the underserved. And the fun fact that you may have heard us talking about if you were joining is that she's very passionate about the duck-billed platypus. And I love that when she wrote this, she put it in singular because we were talking about what the plural version is, but and considers her life's most fulfilling moment to be when she got to hold a platypus in 2017. So our lovely, wonderful, interesting, and absolutely delightful presenters today, Holland and Joelle, are going to go ahead and take over here. And please post your questions in the chat as we go. Marty and I will keep track of them, but we will get rolling. Thank you, Holland and Joelle.
Thank you so much for having us. We're really excited to be here. And I was just saying before, you write a paper and probably a lot of people don't read it. So it's really a great opportunity to have these discussions with people who are really in the clinical field and to hear from you as well. And what we really wanted to do was just talk about some kind of broad themes from our paper and hope that it brings up a lot of discussion. Both Dr. Kaplan and I have, we're fellowship trained in clinical ethics, but we have really different backgrounds. So I'm, my background's in biomedical ethics, and I'm really interested in the patient and the family side and how they make decisions and the context of their decisions and values elucidation. But I really lack the clinical perspective and the clinical expertise that Dr. Kaplan really brings to the table. So it was an amazing collaboration to be able to kind of work together to think through these issues of what you do at the end of life when a patient is minimally interactive and the family and the team are kind of in conflict about what to do and what appropriate care is. And so we were able to bring our perspectives together to kind of think through this. And I don't know if you want to add anything to that.
Yeah, it was a pleasure working with Joelle on this. She undersells her clinical experience a little bit. I mean, the clinical ethics fellowship that we do at Baylor has a lot of clinical exposure, and so it was great getting Joelle's perspective on a deeper perspective on some of the ethical issues, and then just kind of her background more in humanities as well. So it was a great project to work on, and I'm excited to have the chance to talk to you guys about it and to hear what you guys think too. I think it'll be a good discussion.
And yeah, so when we're trying to think through these issues, we found this concept that we thought might be really helpful. This concept of social death, which very generally is a loss of social attributes that put someone's moral or human status into question. And this is really coming from sociology and anthropology, and more recently is typically used to describe how certain socially segregated populations are marginalized or dehumanized. So, for example, slaves, the incarcerated, the institutionalized, people with dementia, refugees. They're somehow socially segregated and therefore kind of treated differently because they're kind of lacking this social abilities or social resources. But actually, really interestingly, it first emerged in the clinical setting. So sociologist David Sudnow in the 1960s, he did an ethnography where he sat in 2 different hospitals for 6 months each, and he really just observed what was going on, the clinicians and how they interacted with patients and families. And one of the things that he found that was really interesting was that when patients were near the end of life and they weren't socially interactive, what he called either comatose or senile, that a lot of times they were treated as if they were already dead. So in this very literal sense, being treated like you're dead. And so to kind of unpack this concept a little bit, I offer kind of like 3 different elements of social death. First, the perceptions that a person lacks important social attributes, such as, for example, agency, social interaction, connectedness, social importance even, or the ability to function as a social being. This perception comes first. Secondly, some kind of discounting of someone's moral, legal, or social status based on these perceptions. And thirdly, differential treatment because of these perceptions. And again, this can be applied to many different settings, but in its original construction, it was really about how clinicians treated their patients. And here's a quote from Sudnow's book, Passing On, where he writes about his ethnographic research. Social death within the hospital setting is marked by the point at which a patient is treated essentially as a corpse, though perhaps still clinically and biologically alive. And he offers some examples. He said things like they would start phasing out treatments before a patient died, or they would talk about a patient as if he or she wasn't there. Sometimes he even noticed that some clinicians would start wrapping the body before it was declared dead, or they wouldn't assign rooms to patients coming in through the ER if they're like, well, they're going to die during the night anyway, let's just put them in the in some kind of storage closet to die. And these seem like very irksome and archaic phenomenon. But we were really wondering, is there something in this perception that someone's no longer socially viable that might cause people to think differently about the appropriate treatments that they should get? And so we wanted to present a case. And this is not an actual case. It's more like an amalgamation of many of the different cases that we've seen as clinical ethicists, or Holland, I'm sure, in your clinical experience outside of clinical ethics as well. So it's not a specific family or patient, but a very, very kind of accurate example. So let's say this patient that we're going to talk about has multiple complex comorbidities and is admitted to the ICU with acute respiratory distress syndrome with worsening pneumonia. His hospital course is complicated by hemorrhagic stroke with no options for surgical intervention. And he is intubated and sedated in the ICU. But as they try to lift sedation, he continues to be minimally interactive. And the team just describes any kind of movements as spontaneous. And at this point, the critical care and neurology teams believe the patient has a very low chance of significant neurologic recovery. And they're starting to even feel distressed about this continued ICU care when they think, well, there's not going to be any kind of meaningful recovery for this patient. And they're saying things like, we're actually not helping this patient anymore, or, this is no kind of quality of life. And so they say, it's time for goals of care discussion with the family. So they get the family together and they talk about the patient's condition and prognosis, and they recommend comfort care. But the family is actually very upset about this recommendation. And they say, what do you mean? I mean, he's still squeezing my hand, when I hold it, or he's blinking when I'm talking to him. And you might want to give up on him, but he's still there. He's still in there. I'm not going to give up on him. And they want to continue intensive care. And so in this scenario, even we can assume that both the team and the family agree on the condition and prognosis, but what really is different here is their perception of how socially aware or the ability to socially interact of this patient.
So I'll briefly talk about how our perceptions of social death can impact end-of-life decision-making in our conversations that we have with patients or more commonly with their families. So I think one of the points that we make in the paper is that it's very easy to make the assumption that social interaction is critical to a meaningful life, and without it, that there's really no benefit to prolonging biological life. And we make a couple of different arguments like this in the paper. I think a lot of these arguments involve quality of life judgments that could stem from a biased perspective, and some biases that I think a lot of us probably have. So I'm going to talk about a couple of different types of different ways that things can impact end-of-life decision-making in relation to social death perceptions. So the first is regarding bias. So social death perceptions can lead to bias on the part of clinicians that have a negative impact on the way that they relate to both the patient and their family. So I think one thing to think about is that social death perceptions can be dynamic. Sometimes it's unclear whether a patient's movements are intentional or if they're reflexes, and this comes in with like squeezing the hand or perceived kind of blinking in response to a family member's presence. And then they can also be changed by clinical changes, the clinical course is evolving, or the level of sedation as well. And this is our perceptions and the family's perceptions. So these perceptions of social death that we have can be impacted by personal experience, social characteristics of the patient, and then the clinician's relationship with the patient before they entered this sort of minimally conscious state. They can also involve judgment of what the social, quote, value of the patient is, and just assumptions about what constitutes a good quality of life. So moving on to the conflict category here. So I think clinicians' perceptions of social death can also lead, and I think we've probably all experienced this, to conflict with the patient's family. So when a patient in a minimally conscious state seems to blink intentionally or squeeze a family member's hand, we may interpret this as a reflex, whereas the family might interpret it as a meaningful interaction. And whether or not it is intentional or not on the part of the patient is not really necessarily relevant in this case. It's a kind of more about the perception of the family. But our interpretation, or if we try to explain to the family that we think that this is more of a reflex, this can lead to the family feeling like their perspective is being invalidated, or that we're discounting the social value of their loved one, or the hope that they're getting from that interaction. So in our paper, we make a couple of recommendations about this, like referring to the patient in the present tense when talking to family members instead of in the past tense. And then when goals of care are shifting to be more comfort focused, using that as an opportunity to connect with the patient and the family and who the patient was as a person, which is something that we should be trying to do, of course, all the time, but really using that shift as a time to emphasize this, because I think a lot of families, which I'm sure you guys experience all the time, can feel a little bit abandoned in those situations. And then lastly, discrimination. So social death perceptions can lead to treatment decisions that are based on how socially viable the patient seems. And so we mentioned this in the paper as well, that the idea of social death can be used to describe how vulnerable populations that are already kind of segregated from society are in some ways further marginalized. So like Joelle mentioned, individuals who are incarcerated, refugees, people with dementia. And I think this is helpful for understanding how social death perceptions can lead to differential treatment of these patients who are minimally interactive. So next slide. All right, so I'll briefly go through some of the recommendations that we make in the paper, and then we'll go into some questions and for discussion and hearing kind of your thoughts about what we've talked about. So the first recommendation that we make is to build awareness of your own perceptions of social death. And then if you want to click, yeah, okay. So these are some of the types of self-reflection questions that we propose. So how am I assessing the patient's social interactivity and viability? Am I incorporating the patient's known values and preferences into my assessment rather than relying on assumptions regarding the patient's social viability? And how and why might the family's perceptions differ from mine? And then next is identifying relevant patient-centered factors for end-of-life decisions. So how confident am I in the patient's prognosis? Could other non-clinical factors impact it? Are we at the point where the patient has irreversible neurologic injury, or are we kind of not entirely sure on the prognosis yet? And how might that impact our assumptions, again, about the social viability of the patient? And then what are the patient's known preferences regarding socio-interactive attributes? So how important was it to the patient to be able to interact with other people? Was this somebody who found a lot of meaning in interacting with their grandkids, or was it somebody who really liked to kind of stay at home, watch TV, and didn't find that to be a particularly an aspect of their life that was one of the more fulfilling aspects? Next is acknowledging families' views and focusing on discussing relevant decision-making factors. So does the family perceive continued meaningful social interaction? And then how are you responding to the family's perceptions? Are you acknowledging their concerns? And then how can you discuss the clinical factors, the relevant clinical information, without dismissing the family's perspective? And then finally, as mentioned previously, affirming the patient's social worth, and then making a conscious effort to continue and try to build on your relationship with the family. So again, how can you affirm the patient's worth and acknowledge their importance to the family? Are there any other accommodations that can be made to support the family and honor the patient? And then are you still, even if you have these perceptions of social debt that you've recognized in yourself, are you still present for the patient and the family, even if the goals have shifted to comfort care?
And so that was kind of like the main things we wanted to share with you, but we wanted to definitely allocate enough time or at least half the time to actually discussing these and hearing what your experience has been. Have you experienced similar cases where maybe you disagree? The team disagrees with the family. I've also had cases where the team feels like there is the patient still is socially viable, and the family is like, no, this is not what they wanted. We want to withdraw, and the team's like, no, give it time. And so I've seen it from both perspectives, but there can be conflict there. So these are just some sample questions, but we're happy to talk about anything that you're interested in or field any questions that you have.
Thank you, Joelle and Helen. That was really wonderful. I don't see any questions in the chat yet, but I do see that Marty has his hand up, so I'm going to let him go first.
All right, so I've got a question about sort of system level bias and discrimination. So I struggle with bias that is more on that higher level than an individual clinician level, because I work at a gigantic hospital, and if we can't see eye to eye, there's going to be a new clinician on next week, and so I got another shot. But in years past, I've briefly worked at a very small rural community hospital, and I noticed how similar everyone was there. I mean, across the board, social work, nurses, clinicians, even their leadership. And I remember being consulted to meet with a patient who had a very different baseline quality of life from that community. And many of those hospital staff told me about how they had very strong opinions about how they would feel if it was them in that bed. And so lots of moral distress. They felt like they were prolonging this person's suffering, even though that was not accurate. That was not how the patient or the family would have interpreted their value of life. And I struggled so much because I felt like I was up against an entire culture. It was the hospital. It was almost as if the whole community was up against me. And I'm curious what your thoughts are and advice for addressing sort of that higher level bias.
I can start because that experience really resonates with me. So something I've experienced at my hospital that I work at clinically. So Ben Taub is a county hospital. We work with only with, very underserved patients who have nowhere else to go. And we have, I mean, I've taken care of a lot of patients who are minimally interactive. They've had multiple strokes, unclear what the prognosis is going to be, or they have a pretty poor prognosis. And what can happen at hospital levels, like hospital sort of leadership levels that I found, is that sometimes there will be a push for transition to comfort care, or a change in the goals of care of a patient because of their lack of social attributes or perceptions of the value of their life, I think. Yeah. And so from an ethics perspective, I'm always very quick to point out, the concerns about that, but it happens enough that I do find it to be concerning. And I think it is something that that people can kind of jump to in their minds.
Oh yeah, I mean, I think it really speaks to this disability paradox that is very prevalent, and it is hard because in these bigger hospitals, they have conflict and they just call the ethicist, and it's like, oh great, we have an ethicist, they'll hopefully sort it all out. Which sometimes I want to call an ethicist when I was on a case, but anyway. But I think it is harder in these smaller, more insular institutions where you're going to be fighting more of this bias. And I don't know if I have an answer to that, except Holland, we gotta do some more work on that.
Yeah, the not solution, but the proposed approach that I try and take is to reorient everybody to think about what would have been important to the patient and what is important to the family. And especially if we have any sort of stated preference or wishes from the patient, which isn't always the case, but if they're there, then it can be helpful to point out, like, hey, based on specifically what the patient has said actually in the past, this is a meaningful existence for this patient. And it's very clear that the family is still finding meaning in it. And so we need to think about this from the patient and the family's perspective. Of course, hospital administration can have other priorities like resource allocation and opening up beds and, and that sort of thing. So they have their own perspective, but it's important, I think, for us to step in and make sure that we're practicing patient-centered medicine.
It feels almost like in those scenarios, I'm having a family meeting with the community and I'm naming the elephants in the room for them, just like I do with families, and just trying to put it out loud so people can think about it and hear about it. All right. Thank you, guys.
I see another hand up, Lindsay McKenzie. If you want to come up.
Okay,
yeah.
Can you hear me?
Yes.
Sorry, I was having trouble coming off mute. So this, I guess, just is more of what you just expressed, but I think it really highlights the importance of these goals of care conversations, because we see it so often in palliative care where there are people who are getting more care than they would want because they don't find their quality of life acceptable. And then there's these situations where there's an assumption that we should give less care when the person may find their quality of life acceptable. And it's just about exactly what you've expressed. Like, we meet them where they're at and then advocate for what's in line with their goals, because we can't just make assumptions as clinicians based off of our own bias. But another thing that I feel like is worth noting or thinking about is when there is very little engagement from the patient and we're considering what would be acceptable for them. Sometimes it's a question of the family may find that is reasonable quality of life, but also I find it's important to understand what's at the root, because oftentimes when they see these meaningful signs that are very small to us as clinicians, they may not find that as reasonable quality of life, but they may find hope in that the patient is going to improve and get better. And I think that there's a nuance there of understanding if they find it meaningful versus if they're finding hope to a path for a more meaningful quality of life, because that can make a big difference as well.
That's such a great point. And from my experience, we point this out in the paper as well. And this this was Joelle's thought in the paper, that when families indicate that a certain movement or blinking or hand squeezing has meaning to them, it could mean that they think that the patient does have an acceptable quality of life, or that it would be meaningful to the patient in some way, that this is sort of the state that they're in. Or it can indicate also a perception about the prognosis that may or may not be true. Or it can even just indicate hope. And people are allowed to have hope, even if kind of clinically we've, I don't want to say given up on the patient, but we feel confident in our clinical assessment that the patient is not going to improve. So I think that's a very astute observation.
Yeah, and kind of going off of that a little bit, I think it takes a little digging, and I mean that's where kind of there's just this privilege in having someone like an ethicist or someone who is able to kind of sit down with the family and kind of sort through their feelings and thoughts, because when they say certain things, we have to kind of interpret what that means, and we can't do that accurately without kind of asking them, like, oh, what does that mean to you when he's blinking his eyes? What does that mean to you? To understand, is it about hope? Is it about, just you don't want to feel like you're pulling the plug on someone who's alive? What is it about that that's meaningful? And I think another thing worth mentioning too is that sometimes the family might think that the quality of life is acceptable, whereas the patient would not. And it's hard to kind of differentiate those things. And again, that takes some conversation about not like, so what would this patient want for themselves, but rather like, what's important for this patient? What was the thing that this patient loved more than anything? What was a good day for this patient? And kind of not asking about the current state, because we might be biased in that, but let's take a step back and tell me about your father or your wife or whoever it is, and let's explore who this person is, and then from that we can kind of extrapolate what they might want, even if they didn't clearly make their wishes known necessarily, or the family's kind of hopeful. So kind of helping the family do that, because it's really hard to do that, especially in these kind of like very emotionally laden situations.
Thank you so much. I have a question here from Marty about effective forecasting errors, how we struggle to hypothetically predict what deficits we might be able to accept in the future. And I feel like this does go kind of hand in hand with the disability paradox. They're very similar. And he was wondering how, as ethicists, how much you consider that when you're contemplating a situation.
I think this we might have different perspectives from a physician and non-physician perspective, because I very much, I have to just allow the team to tell me what their, best guess or their recommendations are for that, and just kind of do this values elucidation with the family without kind of making my own clinical assessment, because I just don't have that expertise. But I don't know if you have a different perspective, Holland.
I think what I've found when I'm doing ethics education with residents or students, or just when I'm on service, that really just pointing out that disability paradox exists is actually can be quite surprising to really to everybody. And so just knowing that bias exists, a lot of people don't know that it exists. And so if you just tell clinicians that it exists, then they can already kind of begin to incorporate how some of their projections or prognoses are incorporating that bias. And I've been very surprised to see how people change their perspective just after learning about the existence of this bias.
Yeah, I find that topic also to be very interesting, and in fact had highlighted that and starred it when I was reading through the paper about the disability paradox, and that idea of effective forecasting, that most of us would, who have ability, whatever that may be, would often state things about what we wouldn't be able to tolerate. And yet when people have, an unforeseen change in their abilities in life, they actually often can have very good quality of life, and so on and so forth. And so I agree with you that pointing it out is great. I have one more question, since I don't see any other hands up, but I had noted, and this hopefully is a quick one, but you had commented that having more limited knowledge, and I'm reading right from paper, of the patient's personal identities may cause clinicians to be biased towards poorer prognosis that might impact end-of-life decision. And I don't disagree with that, but I wonder how that interlaces with the idea that we also know that when clinicians know patients really well, they overestimate prognosis. So I guess my question and my thought was, this feels like a, mama bear, papa bear, and then baby bear is just right. Like, it feels like you have to get that just right, but I was curious what your thoughts were about that.
Yeah, I think, again, recognizing that familiarity with the patient has the potential to impact the way that you're prognosticating or treatment recommendations. I think the best comparison is actually how we, as clinicians or healthcare workers, might make decisions differently for our own family members, people that we know very well. And I think it could go either way. My wife's mother is quite sick right now, and my wife is just dying to have a goals of care discussion with her and talk about code status. But I know it can be the opposite sometimes, that people may continue to push for full code and all interventions just because of the hope that we hang on to. So I think, to me, that demonstrates how variable the response is to knowing the patient in a particular way.
And I would add to that, like, even if you don't know the patient, I've seen, like, in the ICU, this just like deference to a patient that is a doctor and how they treat them very differently. So someone that you may not know, but you can very much relate to, and almost like, oh, that could be me or a colleague or something like that. And yeah, I think Helen's totally right. Just awareness of that. And, it could go either way, but when they kind of underestimate, we can see this kind of bigger conflict with the family sometimes.
Yeah.
And this is one where I suspect, just knowing that, I think the data about overestimating when you know patients well is a little more broadly circulated, and I'm not sure I've necessarily seen or heard the converse to be true. So I think this is where knowing is helpful. We are definitely at time, but I want to thank you both for a great topic, a great discussion, a great paper. I want to thank our audience for joining. Marty did put in the code. If you want to get CME, just make sure you text that in. Otherwise, Marty, anything else we need, or?
That's it. Have an awesome weekend.
Thank you all so much.
Okay, thank you, everyone.
Bye.
Bye.
Bye.